Good morning, my head of units, my pharmacists, and my intern colleagues. Mr. Ima, good morning also. Today I'm presenting on the case of nephrotic syndrome in HIV-positive patients. These are the patients' summary. Mr. M is a 35-year-old HIV-positive male on tenofovir, lamivudine combinations, 1 tablet daily for 5 days. Presents to GOPD of University of Abuja Teaching Hospital with bilateral leg swelling, fatigue, decreased urine output. Then the key findings: there's plus 4 protein, there's low serum albumin, which is 2.5 grams per liter, there's elevated serum creatinine, there's hyperlipidemia. That's the case. So in summary now, these are the patient summary. Patient profile, like I said, is Mr. M, 35-year-old male, HIV positive on tenofovir and lamivudine combination therapy for 5 years. Presenting symptoms is bilateral leg swelling, fatigue, and then decreased urine output. Their lab findings, there is a So Mr. M clinical condition now is nephrotic syndrome. What is nephrotic syndrome? A kidney disorder characterized by heavy proteinuria, hyperlipidemia, and edemia. Like the key findings, there's heavy proteinuria. What is heavy proteinuria? Excessive loss of protein in the urine. Then there's hypoalbuminemia, low level of albumin in the blood. There's hyperlipidemia, which is elevated level of lipids in the blood. Then there's edema, swelling due to fluid filtrations. Then elevated serum creatinine, which indicate renal impairment. What are the possible causes of Mr. M clinical conditions? The possible causes of Mr. M clinical condition is tenofovir-induced nephrotoxicity. That is, tenofovir can cause kidney damage, especially with long-term use. Then there's HIV-associated nephropathy, that's HIV-AN. A common cause of kidney disease in HIV-positive patients, especially those of African descent, specifically. Then other contributing factors may be dehydration, NSAIDs, hypertension, genetic predisposition, and then diabetes mellitus. Then what are the roles of diuretic? What are the counseling points to these patients? The counseling points are taking the money to avoid nocturia, that's urine at the night. Monitor urine output and weight daily. Report dizziness or weakness, which may indicate overdiuresis. Maintain adequate self-irritation and risk of electrolyte imbalance, which is you need to check sodium and then potassium balance. Then management of hyperlipidemia and then drug interactions. So the management, we use what? We use statins, like atorvastatin and rovastatin, which we commonly use in Africa, especially Nigeria, for lipid control. There's dietary modification also, which is low-fat diet. Consider fibrate, which is fiber, if triglycerides are significantly elevated. The drug interactions, cautions. You need to be cautious of drug interactions like statin and then the antiretroviral therapy or drugs, risks of rhabdomyolysis, DT interactions. Simvastatin and lovastatin are also contraindicated with some ARTs. Statin or low dose atorvastatin is preferred. Then avoid nephrotoxic drugs like NSAIDs or aminoglycosides. So importance of blood pressure control, and then preferred antihypertensive drug to use. Prevent further kidney damage, that's the importance of blood pressure control. You need to reduce proteinuria and slow progression of CKD. Then preferred drugs, ACIs. ACI inhibitors like lesonapril or ARBs, losartan, they reduces intraglomerular pressure and then proteinuria. Monitor potassium and then renal function when initiating. Then counseling, follow-up, and multidisciplinary care. Then adherence, reinforce strict adherence to ART to prevent HIV progression and resistance. Use field organizers, alarm, or support groups to improve competence. Then follow up. Monitor renal function, that's creatinine, GFR, and then proteinuria. Okay, lipid profile and blood pressure regularly. Frequent visits for dose adjustment and labs. Then multidisciplinary involvement, pharmacists, drug review, adherence support, then nephrologist, renal care and biopsy, then dietitian, low sodium, low fat, and high protein diet. Then if renal function worsens, next step and then pharmaceutical, discontinue tenofovir. Switch to less nephrotoxic ART, e.g. abacavir-lamivudine combination or dolutegravir and a base regimen. Initiate renal replacement therapy, that's dialysis, if CKD progresses to ESRD. Renal biopsy may be indicated to confirm diagnosis. What are the roles of pharmacists? Recommend ART modification to prescriber, educate patients on drug renal dosing adjustment, monitor for drug toxicity and lab parameters, consult on fluids and dietary restrictions, prepare patients and family for dialysis translation if necessary. Prevention of ART-related nephrotoxicity by the pharmacist. Baseline and routine renal functional tests, that's creatinine or GFR, before and during to avoid or minimize nephrotoxic agents. Recommend ART regimen adjustment in renal impairments, and then educate patients to stay hydrated, report urinary changes, avoid other over-the-counter drugs like NSAIDs, advocate for routine urine protein monitoring in HIV patients on tenofovir. Pharmaceutical intervention summary. This does the summary of the drug and then the action. Tenofovir consider discontinuation if nephrotoxicity confirmed. Replace with abacavir or dolutegravir based on regimen. Look diuretics, that's furosemide for edema. Adjust dose according to response and monitor electrolytes. ACI and ARB for BP control and protein reduction, proteinuria reduction. Monitor creatinine. Statin, that's atorvastatin for hyperlipidemia. Start at low dose, which for muscle toxicity, then NSAID. Avoid further nephrotoxic. Pressure cancelling point. Take all medication at the correct timing and daily. Report any swelling, changing urination or fatigue. Avoid NSAID and self-medication. Keep hydrated unless on field fluctuations. Stick to low salt, low fat diet. Monitor BP and weight. Keep appointment for lab and follow-up. Thank you for listening.
Okay, thank you very much, Pharm Yakubu, for your presentation. I think you did justice to it. You got the diagnosis. I don't know if there are questions, contributions. We'll just take